really what that study did was took patients who had originally node-positive disease, then had neoadjuvant chemotherapy, and if they responded well to chemotherapy, meaning the node-positive disease became node-negative, then they did not undergo regional nodal radiation. There were really two categories of patients: those who had breast conservation, and the breast conservation patients were randomized to just receive radiation to the breast or to the breast plus the regional lymph nodes. And the mastectomy patients were randomized to either receive radiation to the chest wall and the regional lymph nodes, or no radiation at all. And really what the study concluded, after looking at these two groups over several years, was that the number of events was very, very small, and that the radiation to the regional lymph nodes really did not improve the patient's outcome. So it really changed the standard of care, because up until this point, patients originally had node-positive disease and converted to node-negative. We would still treat them after mastectomy or after lumpectomy to the breast and the regional lymph nodes. And now we can eliminate radiation to the regional lymph nodes or eliminate radiation totally for patients who had mastectomy, or just radiate the breast in those who had lumpectomy. The main group of patients that this pertains to is those who were originally node positive, got chemotherapy, and then converted to node negative. There's another trial that I am more involved with, and which Dr. Bowie, who's the president of ASBRS this year, is actually leading, but we don't have the results of that trial. That patient takes patients who originally were node positive, and then after chemotherapy, they had a sentinel node that was still positive, and those patients have been randomized to either axillary dissection or axillary radiation, but we don't have the results of that yet. So these are really just the patients who convert from node positive to node negative. Patients who originally had node positive disease, even though they responded well to chemotherapy and became node negative, they still have a recurrence risk. Fortunately, what that data does show us, and this is very good news for patients, is that if they were node positive and they responded well and converted to node negative, the recurrence risk was low, but it wasn't zero. So they need to be followed. And so what we tell patients is that they still need to be followed, both for systemic therapy and for local regional recurrence. But the risk of a local regional recurrence, if they fall into that category where they've converted to node negative, is very low. And that's good news for the patients. So I think the guidelines have been changing. The study is relatively new. It was only reported out last December at San Antonio, and the full manuscript has not yet been published. But I think it is already changing practice. The important thing to realize is there are subtleties about every study that's done. You know, do patients have certain characteristics where maybe we don't have enough follow-up time? So there was one, in fact, there was one group of patients, those who were estrogen positive and HER2 negative, which is a very common scenario. And those patients, it looked like the radiation maybe did do some good. So I think it's important to look at the very, very specifics of the trial outcome and look at the very specific characteristics of each patient. And then in collaboration with the surgeon, the medical oncologist, and the radiation oncologist, say, well, does this patient really fit the criteria for the study? Are they really at low risk? Or are they one of the groups that's in a little bit of an exception, and maybe we still want to radiate them? So it's still very important to have that multidisciplinary discussion, and that these patients continue to see a radiation oncologist who can assure them that either they don't need radiation, or maybe they fall into a category that's a little subtle findings, and maybe they might benefit from radiation. So There are still unanswered questions, as every trial that's ever done really raises some questions as well as answers some questions. I think the strength of this trial, though, is that it answered a big question that we don't have to radiate everybody that responded. And in fact, we don't have to radiate the majority that responded, but there's still some subtleties of patients where we have to be careful and select who we might treat.